So I'm Jeff Smith. I'm the Medical Director for Education Reform for NHS England, and I've been supporting Chris Whitty and Steve Powis in delivering the medical training review. The background to the review, you'll be very, very aware of. We have seen a number of challenges and changes in the way that the doctor workforce has moulded itself over the last 10 to 15 years. Um, the first of this is the huge growth in resident doctors working and training less than full time. Even over the last 4 years, we've seen a growth from an overall number of about 15% to an overall number of about 25% of resident doctors working and training less than full time, with significant variation in the spread um, of, across specialties, but certainly for pathological specialties, slightly over the average at about 32% at the moment. And that has both training implications, but also workforce implications that we're going to have to think really carefully about how we manage. The second is the shape of the workforce has changed dramatically. So while there has been increases in national training programme numbers, there's also been a very substantial increase in local employed doctor numbers across the United Kingdom and certainly in England. And I think, as we're all aware, this group of doctors are at risk of being somewhat directionless in their development. If they're not supported well by their employer, then demonstrating progression becomes a real challenge for them. The third big issue is a subject that's very close to the hearts of many resident doctors and indeed their faculty, which is the astronomical increase in the application numbers, certainly at core and run through level, across all specialties that we recruit to. Last year, we estimated that we would have getting on for 100,000 applications in round one and round two of recruitment, with the number of posts not increasing dramatically. And indeed, that's borne out for histopathology, where the competition ratios since 2013, down at the bottom of this table, have really escalated. However, we absolutely recognise that there are changes in behaviour from our applicants that have modified that. So whereas when we look at 2013, 2014, individuals were applying for one or maybe two programs, we're now seeing individuals applying for 4, 5, 6, or in one case, 17 different specialty training programs, which artificially increases the competition ratios. And I think we absolutely recognise that that's a response to the concern that getting into specialty training has become harder and harder. And that's borne out by our fill rates. So if we look back to 2017, 2018, several of our big programs just did not fill. And certainly when we look at areas outside of London, Manchester, and Birmingham, to regions such as my own in the southwest, filling our specialty training programs was a significant issue for us. Over the last 5 years, and this in part is a response to increasing applications from those who did their primary medical qualification outside of the UK as a result of the visa rules, we've seen the vast majority of programs fill, although I would note that we still really struggle to recruit to some programs, and I would count histopathology as one of those, and also some of the specialist histopathology pathology programs where we have struggled to fill all of our training posts. So those competition ratios really hide a lot of detail underneath them and possibly shouldn't be taken at face value. We need to think a little bit differently about how we develop that medical workforce. So as we've been developing the medical training review, and for those of you that may have missed it, we published the phase 1 report on the 24th of October, so a couple of weeks ago. What we've done is develop some principles for how we would approach substantial reform of how we train the medical workforce in the UK. The first of these is that we want anything that we do with medical education and training to be evidence-based. There has been a a sort of iterative process of reforming and changing education pathways, some of which have not been entirely evidence-based, and as a result may not have delivered quite what the intention was. The second part of that is it's really important that everybody who has skin in the game, if you like, has an involvement with this reform programme. So that is resident doctors, that's faculty, but it's also clinical services and it's also patients. And that's been a fundamental process through phase 1 and is really key to phase 2 as well. We're really aware that there is plenty of data that shows that both our recruitment and selection processes to training and also the assessment processes within training are not fair. We see significant variation based on protected characteristics in selection, but also in place of primary medical qualification, which we really are going to need to address. We also see those differences through ARCP outcomes, collegiate examination outcomes, and indeed in professional standards outcomes. We see, and you'll be very aware of this, GMC have demonstrated that there are a variety of groups who are more likely to be referred to GMC, and the Fair to Refer programme aims to try and resolve that, but we've got to recognise that this seems to be throughout education and training of doctors. The third is that we have a responsibility to have the right doctors in the right places to look after our population, and recognising that that population demographic is changing and their health needs are changing as well. And as many of you will know, Chris Whitty is a real expert on the challenges of providing health in deprived areas, but also the challenges that result from a population that is becoming older with increasing multimorbidity. And the increased duration of life expectancy when you're well is part of that, but there's also increased life expectancy while you're unwell. So managing an unwell population is becoming a bigger and bigger challenge. And that is heightened in areas of deprivation, but also away from the large conurbations as individuals choose to retire to coastal and rural regions rather than staying in the cities. So we've got one of our principles is that we have got to think about how we distribute the medical workforce and how we develop a medical workforce in those areas of significant health inequality with the right skills to look after the population that we're here to serve. We absolutely recognise there's also a need to think really carefully about how we improve the working and training lives of doctors as they embark on and travel through their career. We've heard loud and clear that there are very, very significant concerns, and that's not just about pay, although pay has clearly been a lightning rod issue recently, but it's also about bottlenecks. It's also about the shape of training rotations. It's also about what often feels like a loss of relationship between employee and employer. And I think we've got a really important piece of work there to think about how we improve that. And we absolutely recognise that there are real tensions in this conversation. There's a clear tension between the autonomy of choice and the desire for agency that an individual doctor has about where they work and in which specialty. There's a real desire demonstrated by the data I was showing you earlier on to work and train more flexibly. And that's not just about reducing or changing the hours that an individual works. It's also about being able to step into and out of training and move between training programs a little bit more fluidly. And also a recognition that there's a real dislike of the complexity and what is perceived as bureaucracy of our current training processes. And we've got to find a way of balancing that against the population health need and really think through how we get accurate workforce planning, an understanding of what that local population health need is, and think about the solutions that we will need to deliver to meet both the aspirations of resident doctors and also the needs of our patients and communities. So, and I'm sure you've all read the medical training review. For those of you who got to the end of all the appendices, all 178 pages, congratulations. I appreciate it's a hard slog. But we were really keen to make sure that we presented the data and the information we'd heard back. And to put numbers on this, we spoke to or had input from 8,000 or so individuals and organisations in developing this review across all resident doctor groups, faculty, services and patients. So I think we have got to say a good picture of where individuals' concerns are. And that has really fed the first recommendation that we made in the review, which is that there is a real appetite now for us to completely think differently about how we educate and train a medical workforce. When we've done surveys of the appetite for reform, over 85% of our respondents say that now is the time to think differently about training doctors. So we've got a real opportunity to now and a mandate to take this forward. The next two recommendations really reflect the level of priority and anxiety that resident doctors have about things that impact on their training. So the first is addressing bottlenecks, and much has been said about this. We are actively looking at how we do this, and you will have seen some stuff in the media from West Streeting this week about some of the work that's happening, both around expanding training, but also around looking at how we would support individuals who are already working in the NHS to come into training. The third is around flexibility, and that covers all the aspects I spoke about earlier on. Recommendation 4 is an interesting one and really recognises the need to support locally employed doctors in their training and development. And through the work of Geeta Menon, one of my colleagues, and many others around the country, we are beginning to look at how we may support locally employed doctors in moving more seamlessly into education and training, but also measuring the capabilities they develop while in locally employed doctor posts so that that's not perceived as wasted time. And I think we've got real opportunities there with our employers to think differently about supporting that increasing group. Some of you will know we've been working with the BMA and the Department of Health on a rotations review. We are looking to pilot new models of rotations being recruited to this year to start next year. And that work will roll into a bigger piece of work within the medical training review to think differently about the geography across which an individual rotates as they train, but also the frequency within which they change post within a rotation. Recommendation 6 very much plays to the discussions earlier on about making sure that we have a medical workforce in the right place. And recommendation 7 is really a key one for me, which is around how we support doctors to be educators. Chris Whitty and Steve Powis have very clearly said that they would expect any doctor to be an educator. That's a little different to being a trainer, but we need to fundamentally rethink how we deliver that teaching workforce to support the delivery of a future medical workforce. One of the things we heard loud and clear during the review is that there are real challenges for those in procedure-heavy specialties in developing those procedural skills at a time when clinical services are under a huge amount of stress to catch up. And I think we recognise that we are going to have to think of different models to support those in those specialty groups, particularly early in their training. So that is going to be a key work stream. For those of you that have looked at the 10-year health plan, GMC have been asked to take on reviewing training curricula, and we are going to work hand in hand with them in delivering that. I'm going to skip 10 and come back to it, but 11 is very much around how we support the development of both clinical academic workforce across the country, but also supporting every doctor to have greater exposure to and expertise in academic pursuits. And that may be teaching and training, that could be leadership and management skills, quality improvement, clinical research, or indeed lab-based research. And the reason I leave 10 till last, which is around changing the way we recruit doctors into training, is that I'm really keen that we move away from a rigid recruitment model that defines how we run programs and into a model which is fairer, but also responds to the need of the training programs themselves. And I think we are going to need to think a little bit about how we change recruitment to support those working and training less than full time, who can often find themselves out of sync with training programs if they're not careful. And the other bit of that is working out how to recognise excellence. And one of our key discussions has been that while it's easy to measure excellence in academic pursuits and academic outcomes, it's harder to measure clinical excellence and excellence in medical practice. But maybe that's a more important thing for us to be thinking about. So I just put this up, and I don't expect you to read it all, but this is just a reminder of the complexity that we have in the system. And this is really why what we can't do is change the whole process at pace, because frankly, we'll get it wrong and there'll be lots of unforeseen consequences that will actively reduce people's experience of training rather than improve it. So as we take this work forward, we are going to have to really think across that complex jigsaw of how we train doctors in the United Kingdom, and really take on how to develop a program that is integrated and fairer without breaking some of the really good stuff that goes on in our education and training. We've identified basically 8 key work streams to take this forward. The 2 in grey will almost certainly be led by organisations other than NHS England, in that clinical academic medicine is really the domain of NIHR and the other academic organisations in parallel with medical schools, and the curriculum work will clearly have to be led by GMC. But we are beginning to work through how we are now going to build these work streams and start getting the ideas pulled together as to how we may change and improve education and training. The timescale for that, well, as I say, phase 2 really launched on it a couple of weeks ago in October with the release of the phase 1 report. We are going to start to run stakeholder meetings in November. And what we're reaching out for to all organisations that have been partnering with us in this work is your blue sky thinkers, the people who can look at this series of problems and challenges and help us come up with some really innovative and different ways of educating and training. There are some short-term things we can do, for example, with the rotational pilots, that we can do almost in isolation because they don't have wider implications. And we are going to get on with doing that, with a plan that towards the end of this financial year, so February, March 2026, we will be pulling together some of the early ideas and models for the future of training. And then the work streams will take those on and start developing them into a series of proposals that we will then come out and consult on. So that's the timeline. It feels fast. To be honest, I think many of the bigger changes are going to take several years, both to agree and to prepare for, rather than putting into place. But as I say, if we don't think differently about it, we won't change anything.